Hello everyone, myself Dr Farhan Khan from Andhra State Medical University. Today I'll be discussing about the auscultation of lung and its main and additional respiratory sounds. First of all, the rule of auscultation. The room should be clean and silent. The patient should be undressed. There should be no clothing on the patient. The skin should be hairless of the patient. The pedal of the stethoscope should be held by the thumb and the finger and pressed firmly and uniformly to the patient's skin. The order of auscultation is similar to compared to the percussion of the lung. That is, first we have to auscultate the anterior surface of the chest, then lateral surface of the chest, and posterior surface of the chest. There are steps to auscultate the chest as shown in the figures. From the anterior view, you can see from lateral view, and from posterior view. There are also a classification of the respiratory sound, which as main sound there are vesicular sounds, which is also known as alveolar breath sounds, and bronchial sound, that is laryngotracheal sounds, and adventitious or added sounds of the respiratories are rales, crepitae, and pleural friction sounds. So first of all, the vesicular breath sound are generated by the vibration of the alveoli wall due to the airflow in inspiration. A long soft noise gradually increases and heard through inspiration. Alveoli wall still vibrates during the initial stage of the expiration and gives shorter expiratory sounds during about 1/3 of the expiratory sound. Vascular breathing is also known as alveolar breathing. Second, bronchial sound. Bronchial sounds are generated by the tubular airflow in the larynx and the trachea when air passes through the vocal slit. These type of breaths are also known as laryngotracheal sounds. And there will be there are many pathological varieties of bronchial sounds, such as our amphoric sound, metallic sound, stenotic sound, and mixed, that is also known as bronchovascular sound. And now we talk about adventitious sound. There are mostly three types of adventitious sound heard in pulmonary pathology, that is rales, crepitation, and pleural friction sound. Rales, first of all, we have sibilant rales, that is also called wheezing, a relatively high pitch whistling sound, musical sound heard during inhalation and exhalation. Wheezing sounds are mostly due to obstruction in the small bronchi during our bronchial asthma. Then we have sonorous rales, that is also known as ronchi. Ronchi are relatively low pitched snoring sounds. Ronchi are generally vibration of viscous secretion or in the widespread obstruction of the median and large bronchus. There are also moist rales, also known as crackles. First, I would like to talk about fine bubbling crackles. They are generated in the small bronchi and bronchioles. These rales are soft, high pitched, short, interrupted cracking sound. Then we have to talk about coarse bubbling rales produced in the bronchi of large caliber, large bronchioesthetis, and also in the fluid connecting lung cavity, communicated with large bronchus. Coarse bubble rales are loud, low-pitched, and louder bubbling sounds. Lastly, I would like to talk about pleural friction sound, which is also known as pleural rub. Friction rub is diagnostic adventitious sound of pleuricity. Pleural friction rub, they are dry, low-pitched rubbing or grating sounds on inhalation and exhalation, heard loudest over the lower lateral interior surface. Lastly, I have added some videos related to the sound. Please.